Good evening and welcome back to the QRME Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. For our second case presentation tonight, Dr. Hollie Berghofer will also be presenting a case on zoonoses. Discussing the case tonight, we have a specialist and expert panel consisting of Dr. Jim McConochie, a rural GP and medical educator with QRME. We have Dr. Stephen Yates, an SMO from Warwick, and also Dr. Antony Faa, an SMO from Warwick. And we have Dr. Penny Hutchinson from the Public Health Unit. Over to you, Hollie.
Okay, so our second case for this evening is a case of PUO and the topic of zoonoses. The history is a 69-year-old male who presented to our hospital with a 7-day history of flu-like illness. He describes being run down, general malaise, his generalised myalgia, subjective fevers, diarrhoea, headache, cough, anorexia, nausea and belching, but no vomiting. On systems review, he had no ERT symptoms, no urinary changes, no rashes, skin infections, cellulitis or bites, no sick contacts, no recent travel, and his occupation is a crop farmer in Killarney, which is a very small rural community just outside of Warwick. His past medical history, he has NIDM, past of gout, and he's previously been admitted to hospital with a pneumonia. He takes no regular medications and he has no drug allergies. On examination, his temperature was 38.2 degrees, his heart rate 85 beats per minute, rest rate 20, blood pressure 128 on 57, and his O2 sats were 98% on room air. He was documented to be flushed, but not acutely unwell. There's no jaundice or rash. Heart sounds were dual with no murmur. His chest was clear with good air entry on the left and right sides. Abdomen was soft with mild epigastric tenderness, but no hepatosplenomegaly. His ENT examination was unremarkable with no lymphadenopathy to the head or neck. A septic screen was requested, which was bloods including cultures, a urine MCS and a chest x-ray. So his initial bloods, normal hemoglobin, white cell count which was low normal with low lymphocytes, another thrombocytopenia with platelets of 70, deranged LFTs all elevated, low normal sodium, renal function, potassium all normal, and CRP elevated at 172. His urine MCS was negative, nothing green, and chest x-ray was normal. So our differential diagnoses for this patient: Q fever, leptospirosis, brucellosis, rickettsia, and a general viral illness, non-specified. So the plan was to admit him to hospital, awaiting the results of his serology. He was commenced on 100 milligrams of doxycycline BD. He was given IV fluids, oral paracetamol and ibuprofen, and supportive cares. So he had fevers for the first 48 hours of his admission and then remained afebrile. He was continuing to feel fairly average on day 3, and yet his serology wasn't back. And we continued with our supportive cares. Serology and Cultures returned. We found 2 lots of negative blood cultures. His leptospirosis IgM was reactive, rickettsia negative, the long T word was negative, Q fever results there indicative of a past infection, and we will discuss that later, and his brucella serology was non-reactive. So this was the day he arrived, the 20th of the 5th. Leptospirosis IgM was reactive. There are 20 species of lepto, and Arborea there, as you can see, is the only one I've elaborated on, but it was less than 50 at the time. So the progress from day 4 onwards, he remained afebrile and he started to feel better. He was discharged home with a total course of 14 days of doxycycline. And the plan was to repeat his serology for zoonoses in 4 weeks' time. So this is his repeat serology. So as you can see from the 4th, he had a Borea titer of 1,600, which then proceeded to resolve with follow-up serology. The other species were all negative. This is his panel of bloods with recovery. So his platelets returned to normal range, his lymphocytes improved back into the normal range, and his LFTs resolved back down. He had good renal function the whole time, normal creatinine and EGFR. So the questions on this case, what are the differential diagnoses to this case? What is the clinical picture that suggests a possible diagnosis of zoonoses? How is leptospirea acquired and what is the incubation period? In this case, the diagnosis was made on serology. What other clinical specimens can be tested for leptospirea and why is serology repeated? The patient was commenced on doxycycline before a definitive diagnosis was made. Is this appropriate? How severe can leptospirosis be and what are the complications? And how do you interpret Q fever serology and what's the difference between phase 1 and phase 2 serology?
Great. So, quite a few questions for an interesting case. What are the differential diagnoses? What do you think, Jim?
Well, again, we've seen a slide with the differentials that were put up, but he's a 69-year-old man. You've got to think of normal illnesses in that age group, such as he could have UTIs from prostatism, he could have any other cause of infection, but he's been unwell for a week. He didn't have upper respiratory tract symptoms and he had no history of travel, but you've still got to think of his age. For the zoonoses, and I think any doctor practicing in small towns, even in cities in Australia, you're not going to find it if you don't always remain suspicious. So you have to be suspicious of it, and if you get no symptomatology on specific history leading somewhere, you should always be considering zoonoses. So I think the list they had there was fine. I probably would have had viral illnesses up there, and I would have probably added renal tract causes in a man this age. And also, you know, I know my auscultation of the chest is not 100%, so I would have also done a chest X-ray on him as well. You've got to be suspicious of community-acquired pneumonias. Mycoplasmas, chlamydias, again, he's a farmer in the lung.
Antony and Stephen, anything to add there, or in terms of thinking broadly?
Well, I think an occult bacteremia is one thing that you don't want to miss. So you certainly need to get blood cultures off, preferably 2 or 3, and yeah, depending on how sick the patient looks, you may even need to cover for other bacterial infections. But yeah, I mean, sometimes these sort of patients come up with a staph infection or you know, something like that. I mean, there's a whole swag of viruses, and exactly which ones you specifically consider or test for depends on, you know, how, you know, each clinical case specifically, but there's EBV, CMV, you know, I mean, HIV's in there, Ross River virus, Brahma Forest virus, so there's those. I think they'd be the main 3 areas, but it depends on how long the fever's been going for. If it's been going for a number of days or even weeks, then you need to start considering endocarditis. I mean, that should be positive on blood cultures. And then there's the whole group of non-infectious causes for fever too. So, you know, malignancy, connective tissue diseases, drug reactions.
So I think it can be hard for registrars when they have a case where there's not a lot of clinical signs, but you know that the patient is sick. And we often get reminded to judiciously use our tests so that we don't test for everything imaginable. How do we balance that with sort of being thorough and doing a complete workup for someone with a fever of unclear sort of source or origin?
I think there's one element to history taking that was missed. Harkening back to travelling, had he been overseas? That's the other thing. Ask about history of overseas travel to the tropics. But it seemed, that the treating doctor took into account an occupational history. He was a farmer, so contact with animals suggests possibility of a zoonosis. We are seeing a lot of Q fever in the Southern Downs, and so it behoves us to exclude a zoonosis. And then there was a septic workup. I think urine was collected, and there was blood cultures, and I'm not sure if there was a chest X-ray, but
I think so if we can jump down to asking about Q fever, since that's something that's been a little bit prevalent, what are the risk factors for Q fever? How does it present? And then if anyone can talk us through the serology phase 1, phase 2, vaccinations for it, and that sort of thing.
One thing that we're seeing, and certainly the Darling Downs region has got some of the highest rates of Q fever in Australia. We've got the highest rates in Queensland, and Queensland and New South Wales get the highest rates of Q fever in the country. The epidemiology is changing. We're certainly still seeing it in our more traditional occupations, so our farmers. We don't see it so much in abattoir workers anymore because they are vaccinated prior to working in abattoirs, but certainly in farmers we still see it. Families of farmers, we're seeing a move away from the farming sector, and people who have no exposure history with animals. We know that it's a much broader range of animals now that carry Q fever. Marsupials carry it, ticks. So it's really becoming a question that needs to be asked, and a diagnosis that needs to be considered in a lot of circumstances now because of the changing in the epidemiology that we are seeing even in the Darling Downs, that there's this move, and I think they've even found that nationally. It's moving away from that traditional occupations of the farmer and the exposure to cattle. It's really changing.
Lucy, I think you were getting at before, you can't order these panels of serology for every patient that comes with a fever. So you've got to have some idea of how when are you going to try and focus on these group of illnesses. And I think if you see someone who's got a febrile illness, obviously, with a documented fever too, it's important, and preferably a recurrent fever. And if on good history and examination and targeted investigations, you've got no source of that infection. So that includes having an MSU, obviously, making sure they haven't got any infected lesions on their skin. If they've got chest symptoms, a chest X-ray. I mean, if they had a headache and neck stiffness, you'd do a lumbar puncture. So if all those things are negative, then you start thinking about viruses and zoonoses. I think that's excluding someone who hasn't travelled from overseas. And then on the basic investigations, they often have a very similar picture, which is a low white cell count, or not necessarily a high white cell count. They often have low platelets, and they often have just mildly elevated LFTs. So if you have that constellation of an unexplained fever with those symptoms, then you really should start thinking of zoonoses and start ordering the serology for the common zoonoses that we see. That would be one way of rationalising the testing of it all.
That's great. Yeah. Anything to add there, Jim, in terms of
Are you asking?
rationalising?
Yeah, I agree. And for registrars who are uncertain as to how much they should order and what, I think the zoonoses and things like that are something you can do something about. Most viruses are self-limiting and not that contagious unless you're looking at hepatitis and things like that. Obviously, if the liver function tests are abnormal and you're screening and you started thinking viral stuff, you're going to do the hepatitis viral screens. But there's no point in doing a lot of viral serology if they're not that unwell, if they're likely to be getting better anyway, and you're going to order tests you can do something about that might change your management. Is the secret. I'm no expert on Q fever, but you're talking about the interpreting Q fever serology and
Yes.
the differences between phase 1 and phase 2.
Yeah.
If you're happier to talk about that.
Oh, I mind. Did you want to can we bring that slide up? I get to read these a lot now.
There we go.
So you can see there with the Q fever, the Coxiella burnetii, the phase 2 and the phase 1 IgGs and IgMs. Phase 2 really indicates acute disease, and so generally with serology, what we usually do is, and particularly this one is actually fairly clear because you can see there that the IgM, phase 2 IgM is non-reactive, and on EIA and also on IF it's less than 10, and the IgG is raised. You can see there that the phase 1 generally gives an indication of chronic Q fever, and if you look there, it's not terribly raised here. But so this serology really follows the picture of somebody who's had a previous infection with Q fever. Now, Q fever can often be an asymptomatic infection, so you will find people, and that's one of the reasons when for Q fever vaccination that we always do pre-vaccination screening, is because if somebody has had a previous exposure to Q fever and they are vaccinated, they can have a significant reaction to the vaccine. So that's why it's so important to do the pre-screening. Another test that we're seeing a lot more now, and it certainly makes my life easier, is certainly in the acute phase doing Q fever PCR. And certainly in that first 10 days of acute illness, if you test there, you can actually get the PCR positive. Generally, we often get it where we've only got the serology, and so what needs to happen is we need to show that there's been a fourfold increase certainly in the IgG for phase 2 to confirm the diagnosis of acute Q fever, and that's usually 10 to 14 days between tests.
And while we're talking about serology testing, there was a question there about with leptospirosis and the testing for that. So in this case, again, it was found in the serology, and the question was raised sort of, should we be testing any other fluids, or is there any other sort of specific testing for lepto, and what are the pros and cons of different tests, maybe at different times in the course of the illness?
Certainly with lepto you can do PCR, and that's very useful. Again, PCR is very useful in the early parts of the infection, and sometimes if the onset's been quite a while, then it's important to do the serology as well. With the lepto, one of the things with the serology, particularly when you're looking at the MAT, which is the microscopic agglutination test, which has been shown, which is where they look at the different serobars of leptospirosis. If that's done too early in the illness, then you won't get any positives for any of the different serobars. And so what needs to happen is you need to repeat that about 10 to 14 days, certainly at least from the onset of the illness, and that's when you'll be more likely to see exactly what serovar of lepto it is. And that's very useful, particularly for myself in public health, because it can actually give us an idea of what the exposure was. what particular animal it was that has led to the leptospirosis in that patient.
The different serovars
The
tell
different
you
serovars.
different animals.
So probably most commonly what we see in our area is Pomona, which is related to cattle, and Arborea, which is what this individual has had, and that's rodents or mice.
Okay. Is it in pigs at all? I vaguely remember pigs, but I might
Pigs
be
can
wrong.
carry it. Yes, there's lots of animals can carry leptospirosis. Dogs, cats, and it's a disease that we saw a significant number of cases following the terrible floods that we had in 2010, wasn't it?
2011?
11, yeah, the
11.
terrible floods. We had over 70 notifications for leptospirosis following the floods. We actually had one death and we had several people end up in intensive care. And the majority of them were Arborea. And what did actually happen following the floods in 2011 was that we had a mouse plague. And there was a mouse plague all through Darling down southwestern and went through western New South Wales as well, and they saw an increase in their leptospirosis cases.
And so these are not just diagnoses that crop up in the country, although I'm sure it's more common in rural areas, but sort of, dogs and cats and things as well. So it could be sort of in your suburban sort of areas that,
Yes.
that we should still consider these zoonoses.
Yes, and given the complications of leptospirosis, it is also it isn't a diagnosis that should be there in the back of your mind. It's generally acquired through breaks in the skin, and it's from soil or water that has been contaminated, usually with urine from a reservoir. And of course that's why after a flood it's quite not unusual to see leptospirosis, and it's a big... I shudder every time I see images about floods of people on their surfboards and swimming in floodwaters, because I just think there are potential leptospirosis cases out there.
Alrighty. And the incubation period was another thing that came up. Do you guys know? I'm sort of hogging you a little bit there, Penny. Is it the 10 to 14 days, or is it a bit longer than that?
I think it can be up to about 3 weeks from memory. 21 days, yeah.
21
3
days,
weeks, yeah.
sounds about right.
Yeah.
Yeah. So something to keep considering down the track.
Yes, yes.
Alrighty. Any other sort of ideas about other zoonoses that are prevalent in this area as well? So we've talked about Q fever and leptospirosis.
Yeah, I guess brucellosis is the other, the big three that seem to be tested for. And I've never seen a case of brucellosis, so if anyone has, I mean...
Brucellosis abortus, I think, is the one that's been eradicated in Australia.
Yes, brucellosis abortus has been eradicated through vaccination of stock, but we still see brucellosis suis, and that's feral pigs, and so we most commonly see brucellosis in pig shooters. So it's also an illness that people should, even in urban areas, should consider, because speaking to colleagues down in places like Gundawindi and vets, a lot of people are seeing pig shooting as a recreational activity, and people travel from the cities to go down and do pig shooting, and some people enjoy that as a recreation. So it can often be something to be considered, even in somebody who's living in an urban area, and that's where social history is so important.
So apart from telling people not to go pig shooting, what other sort of advice can we give in sort of a preventative kind of way as GPs? Jim, what do you think?
Well, I think Q fever is a big one, is immunisation for people who are at risk. But then we were talking earlier, I mean, I've had carpenters who go nowhere near livestock, and Q fever does have a dormant spore phase as well, so it can be picked up from, doesn't have to be contact. But I think if people are in those areas, even I sometimes question whether we should test our rural registrars going into country areas for Q fever, because I think that's the big thing, and it's not just serology. Q fever has a cell-mediated
Yes.
type of immune response as well. So you not only do the blood test for screening, you do a test.
The skin test.
Pricking of the skin, and they should be done on the same day and read quickly and immunised quickly within a negative finding. And you'll find, if, as a GP, if people come to you for that, or you're recommending that, your local pathology laboratories would do that. And you don't actually do that in the general practice itself. But so I think be aware of offering Q fever vaccines to people. I guess if you got technical about it, some influenzas or zoonoses, you can recommend the flu vaccine to everyone. Yeah, brucellosis and lepto, I think you just got to warn people to be sensible with handling the contents of urine for pigs and the pig shooters. It's more when they clean them up and they cut them up and put them on their utes.
When they butcher them, yes. And we often recommend that they wear protective clothing. However, it's a group that is very difficult to engage with recreational pig shooters. And I know my colleagues in the New England area of New South Wales have done quite a lot of work in that area, and they are a difficult group to engage.
I mean, 30% of Australians live in non-metropolitan areas or non-major cities, so I don't think we're going to immunise all of them or warn all of them. I think you just got to be sensible, wash your hands, take routine precautions, just general education.
Yes, but the occupation is also another one that's very important, and one that we get concerned about is that there may be vets that they may be very careful to use protective when we're dealing with animals that may have been exposed to this, because there have been cases of vets who've become infected with these diseases.
Are vets routinely immunised for Q fever?
Yes, they are. Yes. It's very interesting, Q fever. The vaccination really is only used here in Australia, probably because we've got the most.
The highest rates.
Yes, and as what Jim was saying, it's in the environment, and it is worth looking at in urban environments, because what we are seeing with urban expansion is that they're building neighbourhoods in areas where there used to be cattle yards and abattoirs, and this organism can persist in the environment. We're also concerned in the mining sector, because they're out there drilling in what was previously cattle country. So, these are groups that, need to also consider these diseases in.
The other zoonosis that was tested for in this case was the other rickettsia, so tick typhus and scrub typhus, which are not that common down here, I think, but certainly up further north they are. And they're worth considering. So even in history and examination, you can ask if they've got any tick bites, and certainly scrub typhus can often have a very almost pathognomonic eschar where the mite has bitten. And if you see one of those in a PUR, you can almost diagnose it and from that. But in prophylactic terms for those diseases, I guess it's a bit hard. I guess repellent when you're walking out in the bush might help with the ticks. The mites that transmit the scrub typhus are very localised to certain areas. So where you've got the mite and the reservoir and a certain species of grass, and they all live in this same area called a mite island, and so the transmission is very geographically specific. So. I think there's a certain island in the Torres Strait where all those sort of factors come together. So, that's an area where you get a lot of scrub typhus. But I think those ones are worth testing for too and considering.
Thank you for mentioning ticks. Can I throw a curveball? I think patients are very concerned when they get tick bites, and a lot of people sort of mention things like Lyme disease. What are the thoughts on Lyme disease in Australia?
I think
The literature is that we don't have Lyme disease in Australia.
Patients won't believe that.
No.
And there's a movement to have it recognised as being in Australia, mostly patient-driven and internet-driven. I think the next generation of doctors will deal with that more than I have had to, but it's, you know, I think there's one university down in Melbourne that does the serology testing, or one hospital, and you will get people occasionally come along and insist on testing, but the ones I've given into have always been negative. I don't think there's been any positive serology documented by in Australia. But people have the classic symptoms of it. And when you look at the symptoms of Lyme disease, it's not that different from other chronic post-viral suffering or post-viral illnesses.
Yes.
So I think blood gets sent off to the United States, where I'm not sure whether the standards and the you know, of the testing, whether it's all ratified and standardised, and I think they get some diagnoses back from that. Whether
Is there cross-reactivity as well that could be giving false positives, like we see in some of our lab tests here?
Yeah, I'm sure that's certainly the case, would be the case, yes. We see it with other vector-borne disease, with particularly our arboviruses, we do see cross-reactivity. Things like dengue fever will cross-react with other flaviviruses, so yes.
Yeah, and you'll get, you'll get false immunology and cross-reactivity for infectious mono is the classic. It gives false positives for nearly, well, for the arboviruses, for measles, for all sorts of viral serology. So I'm sure there could be cross ones with the rickettsia.
Definitely.
And I was going to mention something from, when I was working up fever of unknown origin in children, we typically would also look for Bartonella, the cat scratch disease. If there's a history of sort of interaction with cats, is that a common thing to see in adults? What do you guys think? Would that be on your differential list, or is that pretty low down the list for adults coming in with fever and not much else?
I think they usually have localised lymphadenopathy. So if you've got localised lymphadenopathy and, exposure, and then yes. But without that, I guess any bite can cause if it gets infected, can cause a fever. But you should have a localised, infected wound then too. So I'm not sure about, just as a PUO, whether it's high on the list.
Ones I've always seen are presented with the lymphadenopathy.
Yes, I think.
And you've just got to be suspicious of got any new cats lately or kittens.
Away.
Yeah.
Stephen?
There's a question about, Penny made mention to the seriousness of undiagnosed leptospirosis, and I thought that was a lead on to one of the questions of Hollie's. The patient was commenced on doxycycline before a definitive diagnosis was made.
Was that appropriate?
Yeah, is it appropriate? Yeah.
Well, yes, because as Penny's mentioned, to get the definitive diagnosis takes sometimes weeks for the convalescent serology to come back, so I think it's been shown that prompt treatment decreases the length of the illness and also the severity of the illness. So it's very appropriate to start doxycycline if you suspect a zoonosis. I think you've first got to make sure you've taken off a series of blood cultures, because they're going to show up any occult bacteremias, and I guess the question of whether you cover for other bacteria depends on how sick the patient is. This patient wasn't particularly unwell, so I think we were happy to cover him with doxy and just wait and see.
And I think
because doxy is also a treatment for acute fever, so you're covering your bases there. But certainly right, Steve, about the with leptospirosis, you often get these two phases. And the first phase, it may be just like an influenza-like illness with diarrhoea, but then if you go into the second phase, that's where you get the more severe illness and the aseptic meningitis and multi-organ failure. So there's certainly evidence that if you treat leptospirosis appropriately in the early phases, you can prevent those complications.
Great.
And the doxycycline will also cover the other typhuses, the scrub typhus and
Yeah,
tick
cover
typhus.
those.
So it's a wonderful drug, actually.
And an atypical
And
pneumonia.
malaria too, so.
And malaria.
And respiratory infections.
What if someone's allergic to doxy?
Difficult
You use
question.
erythromycin? I think you do, don't you?
It depends what you're treating, I think. I mean, with lepto, I think benzylpenicillin in the second line. With Q fever, I think it might be cotrimoxazole. I'm not sure what second line in Q fever. Antibiotic guidelines is pretty good for that sort of.
It's always the best
one
to go to.
Yeah.
And of course, if in doubt, call your friendly
Yes.
infectious diseases physician.
Yeah.
That should be the answer for tonight's question.
I mean, it was just mentioned briefly about a zoonotic disease. Influenza is actually a zoonotic disease. Most of our influenza viruses have been derived from animals, and there's been a mix and combination, and then they've become transmissible person to person. And so it is very important to consider that, and particularly people who work, I mean, we think it's a theoretical possibility. People don't feel that it's a common thing that would occur in Australia, but certainly poultry workers and workers in piggeries should always get their influenza vaccine every year because there is that potential for transmission, reassortment of the virus. So it's very important, influenza, and it is a well-known zoonotic disease. There's several new strains of influenza virus circulating in various countries around the world, mainly in Southeast Asia, and they've all been derived from animals, either swine or birds.
I guess the only other one that perhaps hasn't come up, which is maybe a bit controversial as well, would be with bats. Well, it's probably a couple with bats, including like the Australian bat lyssavirus and the Hendra virus, which I don't know. There has been cases in humans as well of the Hendra.
Yes, Hendra virus. We first alerted to Hendra virus back in the mid-90s, and it's named after the suburb Hendra in Brisbane, and people may be aware that's where there are two racecourses, is the Doomben racecourse, and the first known case of Hendra was in a horse trainer, and there was a series of the thoroughbreds in the stables at Hendra that he was caring for, he and a stable boy, and the horse trainer became very, very unwell and died from Hendra. The stable boy actually recovered. Coincidentally, around the same time, there was another horse breeder up around Mackay whose wife was a vet, and they did a post-mortem on a horse that had died under mysterious illness. They weren't sure what it was. He actually had quite an initial flu-like illness to start with, which he then recovered from. But 12 months later, he developed a meningoencephalitis and died. And with Hendra, we've seen probably in humans, there's been about 7 cases and 4 of them have died. We haven't seen cases now for quite some time with Hendra, and I think that's again because of education, particularly of vets, because quite a few vets have died from Hendra. And Hendra is really, it is a very difficult disease to catch. You actually have to have a very unwell horse and be in contact with a lot of the fluids from the horse, so a lot of the saliva and nasal discharge. And of course, when you've got a severely ill horse, the vet's going to be in there getting into the thick of it. And that's where, we've lost some good vets because of Hendra. The other thing we have now with Hendra, which is very, very promising, is that we actually have a vaccine for horses. And so that is now available. It's at this point in time, the horses have to be vaccinated every 6 months, which can become quite expensive, especially if you have a couple of horses. But that's now something that's very beneficial. Hendra it's a group of viruses called the Henipa viruses. And so there's Hendra virus, but what we also find in Southeast Asia is what's called Nipah virus. And it was first identified in the late 90s, and it was transmission from pigs to humans in Nipah, which is in Malaysia. So the Nipah virus has now been recognised, and again, like Hendra, the source of the original reservoir is the bats. So, and we see certainly in Southeast Asia, in places like Bangladesh, we've seen people who actually get directly infected from bats. And I suppose the worrying thing about Nipah virus is that we've also seen in places like Bangladesh is there has been person-to-person transmission. So it's something that we're watching very closely. And because it's so closely related to Hendra virus, it's something that, you need to be very conscious of.
Thank you. Are there any questions from the audience at this stage?
Yeah, can you comment on the diagnosis and management of leptospirosis in the pregnant patient?
Good question.
That is a good
In the
question.
pregnant patient, who would like to jump in on that one?
Well, I think the diagnosis is similar. You suspect it as a undiagnosed. I guess in the pregnant patient there might be a few more differentials in there. I think it can be quite a severe illness, or more likely to be severe and complicated in a pregnant patient. So it would need to be treated promptly and effectively. I guess the problem was doxycycline in pregnancy. So especially when the teeth are being formed in utero, so I guess that's after the 18 or 20 weeks. So if it was in that period when you couldn't use doxycycline, well, basically you'd be asking an infectious disease physician, but I assume that you'd go to your second line drug, which would be penicillin, and I'd have to talk to infectious diseases about how long you treat, and there may be some implications there.
I think you can also use ceftriaxone, can't you?
Yes, I think that's third line. So I think antibiotic guidelines is doxy, penicillin, and ceftriaxone. So it certainly can be treated, but exactly how long, I'm not sure.
Yep.
Great. I just had a question tonight. The issue was raised that if a patient does come back Q fever positive, as with this patient, that patient's unsuitable for vaccination. If for whatever reason a vaccination was given, can you allude to what the clinical features you would look for in that kind of phase after the vaccination, and what the management should be?
The most common thing we see is quite a severe local reaction. So at the site of the injection, you get quite a significant local reaction. I'm not an expert on treatment of these sorts of reactions. I think it's more the immune system is already primed to Q fever from the initial exposure, and so this is the body's immune response to being presented again with that antigen and having a significant immune response to it.
And just following on from that, if someone has had Q fever in the past and then were to come into contact with it again, is it purely a case of immunity and they don't feel anything, or can they have sort of another illness?
Yeah, well, if you've had Q fever and you've had the infection and you're recovered, then you generally are immune to it. Right. There is the incidence, it's very rare, it's probably about 5% of cases can get chronic Q fever. and that's where the disease can infect the heart and the valves around the heart, and so that can that occurs in only a small percentage of Q fever cases, but chronic Q fever is something that you need to be aware of, and that's where, when you're looking at the phase 1 antibodies on the serology, that can alert you to chronic Q fever. Q fever can also cause a fatigue syndrome called post Q fever fatigue syndrome, and that can certainly be very incapacitating for people.
And there's no specific treatment for that, it's just supportive care? Or?
It is. It's a shame that our infectious diseases physician's not here. She has some good theory that if we treat Q fever appropriately in the early phases, we will prevent we prevent chronic Q fever, but also the post Q fever fatigue syndrome.
Interesting.
The cases, there's only been a handful, but the chronic Q fevers, we were talking earlier, you treat with doxy and I think hydrochloroquine is the other drug. It's a combination drug. But I have seen people get that chronic fatigue syndrome without actually having chronic Q fever. Serology doesn't support chronic Q fever, but they can have a chronic fatigue syndrome. And I have a theory that it relates to the degree of fever they have and the degree of cerebral irritation when they're sick, because they can get those sort of chronic fatigue syndromes after any severe infective illness, and you commonly see it following the influenza outbreaks as well.
Yes. Antony.
I was just going to say, with if someone has acute Q fever and you've documented that they've had it, then if they do have risk factors for developing chronic Q fever, and the main one is obviously any pre-existing valvular abnormality of the heart, then they should be really carefully followed up with serology. I think it's 3 months and 6 months and 1 year, and
And echocardiograms as well?
Well, I think that maybe whether you get a baseline echo, because they're not going to have it when they've got acute Q fever, but the place of echocardiogram in following those patients is, I'm not quite, obviously if they've got chronic Q fever, that's the first place they'd look for the focus of it is an echo. But just following up the patients who's got acute Q fever, I'm not quite sure if they need an echo.
I think sometimes you can get some recrudescence with Q fever. It's not as common as, say, with brucellosis, which is the disease that often does cause that recrudescence. But I think if people see that, if they've done serology and they see that the phase 1 is raised, then it's probably be worth to check, doing an echo to check to see what the heart's like and the heart valves, get an idea.
And the other risk factor, I think, is aortic grafts and things like that. They've got those in.
Any more questions from our audience?
I had 2 questions, if I could. The first is about, from a public health point of view, you were saying that in the first screen you should be quite selective with what zoonotic serology you test for, and then start doxycycline because it would cover most. So if the patient gets better and your initial screen comes back negative, do you go for retesting extra serology to find out what the actual cause was? Or do you leave it as the fact that the patient is better?
Well, the thing is, will the patient come back? And that's something we do find with when we get serology for Q fever, and we like to have a confirmed diagnosis. So often we're asking for that second test. And if somebody has recovered and quite well, often they don't see why they need to go and have another test. So we often have to explain one of the reasons why we need to do that and to confirm what they've had.
You should encourage them to come back and do it, because if it's lepto or brucell and they're a rural person, they're still at risk of Q fever, they should be vaccinated in the future or tested in the future with the skin pricking. So yes, you should aim to do it.
Standard screen to find out what the actual initial cause was.
Yes, but certainly in that acute phase, your PCR is a good guide, and often we'll see the PCR for Q fever is positive, but the serology will be negative, and then if you repeat it in 2 weeks' time, then you'll see the change in the serology, and you can be quite happy, yes, that they've had Q fever.
And my second was, having recently had lunch at a cafe recently here, there were lots of bats and trees, and if someone came into a GP surgery saying a bat flew down and scratched them, how would you deal with that patient?
And this is something every GP in Australia should know, is that has to be taken seriously. If the bat is killed, the bat is... You don't go chasing the bat to find it, but I've had people with a dead bat and they've scratched themselves with the bat or whatever. That bat should be sent for an autopsy, and the public health people can organise that immediately. And the autopsies are very sensitive for Lassa virus. If the autopsy is negative, they don't need vaccination, but if it's present, they do. If your bat is not kept, and most of the time it's not, 100% of those people should be vaccinated, and that's done through Queensland Health Public Hospitals, and that usually includes the immunoglobulin as well as the rabies
So
vaccine.
and immunoglobulin after an exposure.
And 100%, because it's 100% fatal if they get Lassa virus, so they should be vaccinated. And I've had one patient this year who's had that done, and one last year.
Okay. What we do at Public Health is certainly if you get someone who's been scratched or bitten by a bat, yes, they need to come and see the doctor. It's very important to wash the wound, clean it with soap and water for at least 5-10 minutes, then apply some betadine or some other antiseptic to it. The other question we may ask is if the bat is available. If the bat, even if it's alive, sometimes what we actually can do is get the bat tested. Unfortunately, it means that we have to euthanise the bat because the way we test it is to test its brain. So what we have around Toowoomba and through our districts is we have registered bat carers who will retrieve bats for us to test. That also gives us an idea about what the prevalence of the disease is in the bat population as well. So if that's not available, we go straight to post-exposure prophylaxis, and that basically is the rabies immunoglobulin and then the course of rabies vaccine, which is 4 doses of vaccine over a period of 2 weeks. And that's organised through the public health unit. So there's no need for the patient, there's no need to write a prescription for the patient to go and get it from the pharmacy. Basically, you just ring public health and we'll organise the delivery so the patient can either come to your surgery if you're happy to administer the vaccines, or sometimes that can be done through the local hospital.
And is there any urgency in the timeframes of getting the immunoglobulin and vaccine in?
We look at a 48-hour period, so we really want to get somebody started on post-exposure within the 48-hour period. We give that time because we can sometimes get the testing done in that time, and if the bat's negative, then there's no need to proceed with the post-exposure vaccination.
I also warn and this gets back to travel medicine, I also warn my travelling people that if they come back having been bitten by a multi or bat or something in Southeast Asia or rabies-prone areas, that even if it's a year later, they should be coming to tell me about that, and I should be referring them to someone who knows more about it to discuss that with them, because some of them should be getting those same vaccines, because rabies has been known to turn up in people as much as 21 years later, I think is the longest, wasn't it?
I've said 6 or 7 years.
6 or 7? Yeah.
So one thing that's very important, and one thing that's a source of frustration in public health, is people go to the monkey forest in Bali, in Ubud, and they feed the monkeys. The monkeys have no fear of them, and the monkeys may scratch or bite you, particularly if you've got a banana in your hand. And so we get a lot of people come back from Bali who require post-exposure vaccination because they've been exposed to monkeys. So Bali, there's been no evidence of rabies in the monkey population in Bali. It certainly has been in the dog population, but historically monkeys can be affected by rabies, and that's why we provide post-exposure prophylaxis. One thing that we are coming out now and saying more is that people who travel, even if it used to be because rabies, if you get pre-exposure prophylaxis, even if you will still require post-exposure treatment, but you don't require the rabies immunoglobulin. And so what we need, I think, to encourage people is, even if they're only going to somewhere even like Bali or Thailand for a short period of time, they should actually consider rabies vaccination, and particularly for children. You know, over 50% of rabies cases are in young children under the age of 15. And it's because young children are, you know, at more close level with a dog or that could bite them or scratch them. They're often more likely not to tell their mum or dad that they've been bitten or scratched. So particularly in young children, we recommend now, if you're travelling to places that are endemic with rabies, that you consider getting your child vaccinated for rabies.
Thank you.
All right. And I think we've got time for one last question.
So I was just wondering, in terms about the lepto, if it goes untreated, what's the progression of disease that you would expect to typically find?
I mean, most of them will, if it goes untreated, I think you can just get better with it. You know, it can be a mild self-limiting illness. About 10% of them can go on to severe disease. So there's a group that we never know about. There's a group that present and get diagnosed, who get treated and who get better. They're basically uncomplicated. And then there's another group of about 10% of those ones which can be severe or even fatal. And that's when you can get complications like meningoencephalitis, the so-called Wheals disease with renal failure. Yeah.
But we're pretty much multi-organ failure.
Yeah, and the pulmonary
hemorrhaging.
Yeah.
It's terrible. It's a devastating. As I mentioned, we had a death back in 2011, and yeah, it was just quite devastating. This person deteriorated very, was in intensive care, and the intensivist worked on them all night, and to no avail. It was, very, very dramatic.
And will that happen in spite of treatment with the doxy, or will it, if you treat with doxy, then that shouldn't happen?
If you treat them with doxy, it shouldn't happen.
All right, well, thank you to our specialist and expert panel for another fascinating discussion, and special thanks to Hollie for her case presentations tonight. But unfortunately, we are out of time. We would like you to join us for the next QRME Grand Rounds later in the year. Please keep an eye on the QRME website for the dates and topics. I'd also like to finish with a special thanks to the support of the digital media services of USQ. That's it for another QRME Rural Medicine Grand Rounds. Good night.